Welcome everyone. This is Dr. Jaitly from New York. I'm on your favorite website, MuniMeterHealth.com, which is dedicated to educating you about the heart illnesses and obviously about the heart awareness. Our major interest is to improve the patient education and in combination with the clinical education which is being provided to the medical fraternity anyway. So this way we can enhance the patient health literacy in the general masses, and that's one of the major initiatives and goals in my life. And now through the video format on MuniMeterHealth.com, your favorite website, I am able to communicate to you throughout the world. So thank you again for watching MuniMeterHealth.com. Without any further ado, let me just quickly do some housekeeping. First things first. Number one, this is a supplement and not a substitute to your text, folks. So just remember, whoever is taking the exams, interns, residents, fellows, medical students, etc., just be mindful that this is a supplement and do not replace your text. Nothing like your text, your whatever that has been recommended by your societies and by your institutions. Number one. Two, again, it's not to be considered as a medical advice. This is purely a teaching education tool that's being brought to you on your smartphones and of course on your computer screens. So having said that, let's delve onto the subject matter today. I'm going to be talking to you about what is peripheral arterial disease. I probably have done one or two short videos earlier also, and you can refer them to those as well. But just to let you know, peripheral arterial disease implies that you have compromisation of circulation within the peripheral arteries. Specifically, we are talking about the lower extremities. Remember that. So let's discuss the lower extremities first. So we have what it looks like is the descending aorta, okay, here, and then dividing into obviously the aorta iliac, we call them, and then of course dividing further later on into femorals and superficial femorals and deep femorals as we go along. So these are your femorals, these are your aorta iliacs, and this is your descending aorta, if you will. So the blood is flowing in this direction. Now if you have the commonest problems that arise are either thrombi, which is related to either atherosclerotic disease, which starts to manifest mostly around these aortic areas, and again normally implying that there might be plaques which could overall period of time they develop, and when they develop obviously the arterial circulation here gets compromised. So thrombi we have talked about, atherosclerotic plaques obviously those will be one of the etiological agents. Peripheral embolization down the stream that can occur. Now remember, the embolizations can occur from the heart, and they can occur from the aorta downstream. So remember that. So either the aortic atheromas that are very prevalent in the upstream areas, like in the upper descending aorta or the arch of the aorta, specifically after the age of 65 to 70, that commonly occurs. The aorta gets atherosclerotic, and specifically so if you have premature atherosclerosis, then of course you can see it even in younger individuals. And from cardiogenic point of view, just remember that the cardiogenic variety is typically the ventricular aneurysms, where post-myocardial infarctions there have been some dyskinetic segments, and as a result the thrombus tends to occur in those individuals. So let's draw this heart for a second, mainly the left ventricle. We're going to be drawing only the left ventricle, remember, in this schematic. So this is your mitral valve obviously here, and the outflow tract is right here. So that's your outflow tract, which is LVOT we call it, and these are your mitral valves, and this being your LV. So what happens is when you have a segment which has infarcted, for instance, say distal, lateral, and then apical segment here has suffered an MI, for instance, what happens, this area is moving outwards during the time when the ventricle is contracting. Remember that. So when the ventricle contracts, this area moves outwards here, whereas this one is moving inwards. So this is called dyskinesia, and that dyskinesia leads to one to develop a thrombus. So that leads to a thrombus formation, and the more longer, again this is time related. So over a period of time, as the heart is beating continuously like 60 to 80 times a minute, this segment continues to protrude outside, and that leads to that makes it look like an aneurysm. So that's called the aneurysm. So an aneurysm is basically a dyskinetic segment following in myocardial infarction usually. You can have pseudo-aneurysms, and we're not going to get into this video, but we'll talk about that at a later time. But just so that you know, dyskinesia secondary to myocardial infarction can lead to LV aneurysm, and this is where then the thrombus begins to form, because this segment is not moving, the blood gets stagnated, and this is where the thrombus is forming. So LV aneurysm, as I said, ventricular aneurysms or LV aneurysms, these are the places where the thrombi will form, and the thrombus will eventually get dislodged, and therefore when it gets dislodged here, so it can go into the left atrium as well, or it can go into the aorta, most likely into the aorta, and that's where it embolizes into these areas, and these thrombi can come down and obstruct, and they can totally occlude these smaller arteries as we go down even into the beyond the femorals, into the popliteal vessels, or into the dorsalis pedi, which is in the ankles, and then in the posterior tibial arteries as well. So this is where, your rest of the extremities, as it, the rest of the tree, for the vascular tree, if you will, in the lower extremity progresses. And the smaller the artery, the greater is the chance that same thrombus or dislodged embolus now gets to occlude the vessel. So having defined these etiologies, now let's move on to further define how do you test for these? Well, the clinical signs and symptoms are very, very important. Well, first of all, remember that it's a disease where the pulse will be reduced, obviously, or maybe absent. So it may be reduced or absent. You may have some hair loss in the region. Remember that the lower extremities you may have. Then the motor and sensory deficit will start to occur. And that, of course, is a very, very serious sign where you have sensory paresthesias, anesthesias, or hypoesthesias, that the patient is not able to experience the skin touch, or the pain, or even the pressure or tactile stimuli in the lower extremity. So these are very, very important symptoms and signs. Do not forget, of course, the loss of function, as I said, the motor function, and pallor will develop, and very rarely a cyanotic, but that is very, very significant disease. So these are your symptoms and signs. Now, depending upon where the obstruction is, say the obstruction is the aortoiliac region, or in the, like I said, aortoiliac region, or the common aortic bifurcation region, or in the femorals, deep femorals, or whether it's in posterior tibials. We can show posterior tibials here if you like. These are your popliteals, for instance, and these popliteals will later on divide into posterior tibials and dorsalis pedi, which is running in the front of the ankle here. So if there is an obstruction, say an obstruction here, then depending upon where the obstruction is, one actually can, based on very astute history taking, and of course the patient has to be remarkably very thorough also defining where the pain is occurring. So the intermittent claudication occurs. What is intermittent claudication? That brings us to the definition of that. Intermittent claudication is pain related to a muscle spasm. Remember that? There has to be a muscle spasm. There has to be a pain, and the site will determine where the claudication is and where the obstruction is. So muscle spasm leading to pain, and mostly on exertion and relieved at rest. Remember that. It relieves at rest. So moment you take the rest, the patient is benefiting. So at rest, it is improving. So that's one of the commonest definitions, and it's a very clue. Now there's a pseudo-claudication. Remember that? There's something called a pseudo-claudication. Now that implies that is originating from spinal stenosis. So just remember that spinal stenosis occurs where you have the foramen from the spinal vertebrae, which is now stenosed, and as a result, the nerves that are coming out of the spinal foramina, they are compressed, and it's called a compartmental disease, which is occurring in the spinal areas. But remember that here the symptoms are very, very typical. Not for claudication, but they are pseudo-claudication. So here the pain will occur on bending forwards. That's a classic history. So patient is, say if the patient is now here, let's draw a diagram here. This is a hill, and the patient is walking, upwards, going up the ramp. Now that is typical of claudication here, by the way. Okay, if that pain occurs, that's claudication. But if the patient is walking downwards, that is typical of pseudo-claudication, because here the patient tends to bend forwards. So when the patient is bending forwards, the pain is actually getting better in claudication. But the pain is when the patient is bending backwards, that's where the pain is worsened. And those patients who are coming down the hill, obviously they're bending backwards. Your body tends to be bending backwards, and that's pseudo-claudication. So pseudo-claudication occurs when you're walking down the hill Typical claudication occurs when you're walking up the hill. So just so that you know, okay? So that's one way of distinguishing these features. Very important test that's coming up is ankle-brachial index, because diagnostic, you need to now, once having ascertained what the clinical symptoms and signs are, your suspicion is high. Obviously, you want to test these patients quickly by bedside. And ankle-brachial index, as it's called, it's checking the systolic blood pressure at the ankle divided by systolic blood pressure at your brachial level, which is your arm. So ankle and brachial, and that's your index. So you can multiply that by 100 and get a percentage, or just get the ratio itself. So anything more than 1 is normal. Anything less than 0.9 to 1 is mild disease or borderline. 0.9 to 0.4 is considered as moderate disease, and then less than 0.4 is considered as severe PAD. Remember that severe peripheral arterial disease is present in these patients, and these are the patients who are going for surgical intervention. So mild to moderate can be managed with medical therapy. This can be managed only with surgical therapy. So remember, severe disease when the ankle brachial, and this test is extremely important. It's been approved now, and most internists, most cardiologists, most vascular surgeons are routinely doing it automatically in these patients, because this way you can really screen all these patients. Now, where do you want to screen these patients? There is a certain degree of suspicion, because suspicion for PAD, whenever you have a suspicion about PAD, you have to try and see which patients really will benefit the most. Obviously, patients who have hypertension, patients who have symptoms, if they have claudication, so intermittent claudication, we'll write it down, I see here, claudication. Patients who are diabetic, patients who are smokers, so they belong to a very high category here, smokers. Patients who have high cholesterol, dyslipidemia we call it, and patients who have dyslipidemia, so very important. And patients also who have hyperhomocystinemia. That's a congenital disease where homocysteine levels are very high, and those patients tend to have premature atherosclerosis, body-wide, I should say. So high homocysteine levels. So if you demonstrate that, and you have a premature atherosclerosis. And then other patients who have other vascular disease, for instance, you have coronary artery disease, documented patients who have cerebrovascular disease, bicarotid disease, or renal arterial disease, if you will. So these are other indications where your suspicion is very high, and you should do obviously an ankle brachial index, unless patient already has symptoms. So even when you don't have symptoms, you can do an ankle brachial index in your offices, in your clinics, and actually get a good hold about these patients, whether they have disease or not. Okay, so in a nutshell, we have talked about the diagnosis of ABI today here in our patients with MuniMeterHealth, in our patients on MuniMeterHealth.com, your favorite website. So continue watching us, and we'll be telling you more and more about peripheral arterial disease in our forthcoming videos. So stay tuned, and we'll talk about the management in our next video, etc. So again, thank you for watching, and sticking around with MuniMeterHealth, because that's your free website disseminating information and education on human heart awareness, vascular systems, and of course educating my interns and residents and my dear fellows who are training and about to take an exams, etc. Or even my colleagues, they want to see a case and from day-to-day activities in their practices, and they want to quickly brush up their skills. Obviously this small little video vignette, I hope, is helping them. So long from New York. This is Dr. G.